Back again, ladies and gentlemen. Part two. Part one was skull and facial bones anatomy. So now we're going to go into positions for the skull. There are going to be positions for the facial bones and the mandible coming up in subsequent lectures. And I think in this lecture, I've also included a little bit of image critique guidelines embedded with the skull positions and what the projections look like. Our ability to find, like I said when we started all this, the cranium and plain radiographs of the head and the face are few and far between in the modern age because of the power of the CT scanner. So I am going to integrate image critique from the standard positions, show you some of the anatomy as it's displayed on a radiograph from these positions, teach you how to tell the difference between the various positions and identify the positions radiographically. So immediately, as soon as you see the x-ray, you're going to say, ooh, that's a lateral. That one's a Caldwell. That's a straight PA skull. This one's a Towns, so on and so forth. So you'll be able to identify the radiographs on site. If we do get the opportunity to image critique some exams, I've got to search the PACS, to be honest with you. I know in the past I've seen some, but I don't know if those disappear in the long-term archive because we switched PACS browsers from the time that I taught this last year. So it's brand new. The Infinite system is brand new. So some of the old exams, I'm not sure if they show up or not. So we shall have to see. All right, so let's get into this. General body position. You can do these standing or laying down, depending upon your patient. Again, assess your patient. If your patient is well enough to stand up or sit upright, you might find that it's actually easier to do the skull exam in the upright than it is supine. However, if your patient has other injuries and or is not able to bear weight on their legs, you might find it wiser to lay them on the exam table for these projections. Okay, general body position is especially important in hyposthenic, asthenic, and hypersthenic. So the alternate body types, the head versus the torso. If the torso is too thin, then especially when you lay the patient on their side, the head tends to oblique. And then likewise, laying the patient supine, if the torso is too large, the head tends to oblique. So you got to be mindful of that when you're laying the patient down, that the head might end up in an oblique posture rather than a true lateral or a true supine posture. Okay. And let's just click those. So here's our table radiography. Here's our demonstration of a lateral skull position with the patient supine. Notice that the torso is in an oblique. Left anterior oblique is going to give you a left lateral head. And then this is the same projection on the upright bucky. So these are all transferable. It's really object ABC is in a vertical line. Just change that to object ABC is in a horizontal line, and you have the upright version of the projection. Okay, and yes, this man got the gig because he's bald. All right. General body position. Okay, usually you need to support or elevate the patient because the C-spine will either lean backwards or lean up a little bit as you're positioning them laying down. And so the C-spine will start to lay a little bit different than square, either in the supine position or the lateral recumbent position. So you're going to have to build the head up with some sponges or something like that, or possibly support one of the shoulders, so on and so forth. Okay. And then patient preparation, radiation protection. You should be able to shield all patients. The gonads are nowhere near, the reproductive organs are nowhere near the head. And then make sure you're taking out the patient's dentures and taking their bifocals off for the projections, because that's what we're actually seeing here is the bifocal lenses of the patient's glasses are showing up on the radiograph. I don't know how glass is attenuating X-ray that well, but it seems to be. And then of course the patient also has, it looks like a denture plate, a partial denture plate in the lower mandible. Both of those could be removed and we get a clearer picture of the patient's skull. This is actually a Waters projection for maxillary sinuses is what it looks like, but they forgot to remove the patient's glasses. So glasses, earrings, necklaces all have to be removed before skull radiography is performed. Hearing aids too, if they can be. All right, so what projections are we talking about for the skull? Lateral, both left and right are routine positions. Understand that most of the time when you're x-raying the skull, it's as a result of a fist fight or an assault in a trauma situation. And so they might have different injuries to the right side of their skull versus the left side of their skull. When will those injuries show up? When OID is reduced. So you get sharper edges. The edge blur reduces with reduced OID. So it might be that for an assault, you might be taking both a left and a right lateral projection for the same study, because the left side of the face might have different injuries than the right side of the face or the left side of the skull, so on and so forth. So getting both the lateral projections, make sure that the radiologist can see the side down with clear detail. Okay, straight PA or a PA axial Caldwell method, and again the APs and the PAs. The reason we put axial and angles on the PAs and APs is to switch the position of the petrous pyramids, the petrous portions of the temporal bone, and get it out of the way of the other anatomy. So that's the major difference between the straight PA and the PA axial Caldwell. There's also an AP projection of the skull that you can substitute in trauma. It's not always handy to lay a trauma patient prone. AP axial Town, PA axial Haas. AP axial can also be a reversed Caldwell in a trauma situation. And then finally an SMV, a submental vertex projection. So those will be the projections that I'm covering in just this lecture. When we do facial bones projections, we're going to modify some of these. We're going to do a modified lateral where we center for the bones of the face, not necessarily the bones of the cranium. And then we'll do a modified Towns for the mandible. And then we're going to add a Waters projection and a reverse Waters and a modified Waters projection next week for the facial bones. So, but for right now, this is what we're going to cover in this lecture, and this is what I'm going to demonstrate to you on Monday in laboratory. All right, so in a lateral projection, the interpupillary line, so a line that cuts through the mid orbits roughly, is perpendicular to the image receptor and running horizontally or running vertically in table radiography. And then the mid-sagittal plane is oriented parallel to the image receptor. And so the way that you do this is you have the patient's torso, their shoulders, and their hips at a 45-degree oblique, kind of like you were going to do a anterior oblique of the C-spine, but then turn their head into a lateral posture with the mid-sagittal plane of their head oriented parallel to the image receptor. Now, where are you going to center to? You are actually going to center to a point 2 inches superior to the EAM. And then open the collimation so that you include all of the frontal bone and all of the occipital bone. Okay, so you should see light above the vertex of the head, like we see there in the picture, in front of the patient's forehead, but also behind the patient's base, the base of their skull, going into their neck. You should see the shadow of the base of their skull. Okay. Now, this patient doesn't have hair. That's very handy. Your patients are going to have hair, so you're going to have to kind of use your x-ray vision to see the border of their scalp and figure out whether that's included within your light field. Okay. Barrettes, bobby pins, hairpins, all that kind of stuff is going to have to be removed for the radiograph, and you will probably make some middle-aged women very upset when you tell them that they have to remove all that stuff. All right. The lateral projection, what's it supposed to show? Well, you're supposed to see the orbital roofs. That is the entire cranial floor, left and right side superimposed with each other. It starts with the orbital roofs, which is actually the ethmoid and the frontal bones. You're going to see the sella turcica. You're going to see the temporal mandibular joints superimposed, the EAMs superimposed, the mastoid regions superimposed. Okay. The sphenoid sinus should be just below the sella turcica. You may or may not see all of the mandible. It might be truncated. You may or may not see all the bones of the face. That might be truncated. The region of interest. See where it says orbital roofs? Yeah, go anterior to that, and you can see the bone of the forehead, the frontal bone, coming up to, if you look, follow that around to the vertex of the head, and you see like a wiggly black line coming down. That's actually the coronal suture that you can see on this radiograph. So you should see the junction between the frontal bones and the parietal bones, and then the parietal bones sweep toward the back, and you may see another wiggly black line right below where it says sella turcica. That's the lambda and the lambdoidal suture. Now the one that I always have trouble finding is the squamosal suture. I know it's there, but it's kind of hard to see. Lambdoidal suture and the coronal suture seem to show up well. I can see those on this radiograph. Sometimes you can see the squamosal suture, sometimes not. You should see all the occipital bone, and the occipital bone, that border of the skull, should carry forward all the way through to junction with C1, and then into the temporal bone and the EAM, okay, where the middle and anterior sections of the cranial floor come out of the EAM and the temporal bone region. So the EAM is surrounded by the petrous pyramids, the petrous section, so the bright white part in the center there, that is looking down the gun barrel, if you would, of the patient's ear, with the gun barrel center being the EAM. Okay. If you don't get good superimposition of your TMJs and the mandibular rami, you might have obliquity. Usually it's a rotation. The mid-sagittal plane is not parallel to the image receptor if the TMJs and the mandibular rami are not perfectly superimposed left to right. Okay, if the you see where it says the orbital roofs, the cranial floor, if that is not superimposed well, usually that's a tipping of the head side to side versus rotating the head side to side. So tipping the head in the mid-sagittal plane, the upper mid-sagittal plane is closer to the image receptor than the lower mid-sagittal plane. That's going to manifest as a non-superimposed cranial floor between the orbital roofs and the sella turcica. it's going to look kind of like there's two of them. Rotating the head left to right, that's going to be non-superimposed mandibular rami and TMJs. Okay. Lateral projections, evidence of proper collimation, entire cranium presented without rotation or tilt. And I just showed you those radiographic signs, or told you those radiographic signs. They are superimposed orbital roofs and greater wings of the sphenoid. That is tilt, if you will. Superimposed mastoid regions in EAMs and TMJs. That's rotation. Okay, especially the TMJs and the mandibular ramis. You should see the sella turcica in profile, superior to the sphenoid sinus. You should have adequate penetration of the parietal region. And you can tell you've got penetration because you can see the venous structure of the on the inside of the cranium. That pattern of the venous structure presented over the squamous region of the parietal bone. Okay, no overlap of the C-spine by the mandible. That will tell you whether or not you have made the interpupillary line a true horizontal and perpendicular to the image receptor. That is, raise the patient's chin so their interpupillary line is horizontal. It's now what's the, oh wait a second, there's one of the, is it the, I want to say it's the infraorbital line is also horizontal. It may be the orbital line, orbital-meatal line, not the infraorbital line. Let me check the book. Hang on. Let me just stop and check the book because that's the best way to eliminate confusion. So I think, is it volume 2? Yeah, I think it's volume 2 is where we find the skull chapter. So let me go again. This is the worst thing a teacher can do, is give a lecture where they purposely they're so careless that they don't check the information to be sure. So it has been, to be honest with you, it's been a while. It's been about a year since I talked about skull positions, and I mean, just like the technologists, we don't use them that often, so remembering the centering points is a little tricky. So there's the facial bones. Where's the section for there's the eye, there's trauma. Okay, I guess it's a little bit forward, a little bit. All right, I'm almost there. Sorry about this, guys. Okay, there's the... Okay, fantastic. On page 34 of volume 2, infraorbital meatal line is perpendicular to the front edge of the IR. So if you're laying them prone, or I'm sorry, you're laying them down on the table, the infraorbital meatal line has to be a vertical line that is perpendicular to the light field, the edge of the light field in the targeting light. Yeah, perpendicular. So the plane of the IOML, that is a line that extends from the EAM to the lower border of the orbit. That line, if you keep extending it to the edge of the collimated field, it should intersect the edge of the collimated field at a perpendicular. Now, if you've got the patient upright, that just means it's a horizontal line. In other words, the IOML is horizontal. I'm glad I checked that because I almost misled you. Okay, very good. IOML horizontal, interpupillary line intersecting your image receptor at a perpendicular mid-sagittal plane parallel to your image receptor. And then the patient's head will be properly positioned. Center 2 inches superior to the EAM. All right, on to the Caldwell projection. Well, how do we do a Caldwell? Well, the patient's nasion is centered to the image receptor. Okay, I'll say that again. Now, this looks like it's centered a little low. Well, it's out of detent is what it actually is. Well, no, because the cassette is riding high. It's not centered to the glass plate. So it's not out of detent. It's just I've never seen a unit like this where you have an off-centered cassette. Okay. All right. Anyway, center the nasion of the patient, that's the divot at the top of their nose, to your image receptor. Then put a 15-degree tube angle on your x-ray tube, 15 degrees cauded. Okay. Tip the patient's chin down slightly so that the orbital meatal line intersects the image receptor at a perpendicular. That's what the white line is. Okay. Tube angle of 15 degrees caudad, and then achieve detent with your tube. That is, turn on the laser light, line it up to the image receptor. So we kind of do the positioning backwards here. We don't really center to the patient's anatomy. The central ray is described as exiting the nasion. Well, the easiest way to do that is, think about object A, B, and C. What we're going to do is take object B and line it up to object C, the image receptor, and then we're going to go back and take object A, the X-ray tube, and line it up to object C, the image receptor. So indirectly, the X-ray tube is lined up to object B, the patient's anatomy. You line both the patient's anatomy and the X-ray tube up to the image receptor, and that's the way I learned how to position a Caldwell. So, because there's no real good landmark on the back of the head as to where should the central ray be entering. It doesn't really work that way. With a Caldwell, the central ray exits the nasion. Okay, 15-degree caudal angle toward the feet, OML, perpendicular to the image receptor, center of the image receptor at the level of the nasion. Achieve detent with a 15-degree caudal X-ray beam, and boom, you have a Caldwell projection. And of course, it's named after the radiologist named Caldwell. We're going to find a lot of methods in this chapter. All right, so this is what a Caldwell looks like. Now, what are you seeing here? You're actually going to see the superior orbital margin, and then just below that, there's another line that comes through. That's actually the floor of the cranium that you can see. The anterior floor of the cranium runs roughly perpendicular in this projection, so you get a good evaluation of the anterior floor of the cranium. Okay, that's the diagnostic value of this image for the radiographer. So you can kind of see the lesser wing or the greater wing right there in the upper third of the orbit. Okay. If you look, you can see the frontal sinus displayed just superior and medial to both those orbits, and you can see kind of like a white teardrop in the middle of the frontal sinuses, right between the orbits. That's the crista galli. And then you can see the cribriform plate on either side of the crista galli, in the cribriform plate, again, being part of the cranial floor. The ethmoid sinus is immediately inferior to the cribriform plate. And then the petrous ridge appears in the lower third of the orbit. I'll say that again. The petrous ridge, which is the superior edge of the petrous pyramid, appears in the lower third of the orbit. Okay? And then the inferior orbital margin is obscured, of course, by the petrous pyramid, the petrous portion of the temporal bone. So there's little white triangles, and the top of the white triangle is cutting through the lower third of the orbit. The maxillary sinuses are obscured by the petrous pyramid, so you can't get a good read on the maxillary sinuses or the zygomas. In this projection, you can get a great read on the anterior cranial floor and the upper margin of the orbits, and the ethmoid sinuses, the superior nasal concha. You get a great read on those in the Caldwell projection. So again, 15-degree down angle. That makes the Christogalli pop up and superimpose nice and neatly over the frontal sinuses. You can see the superior orbital margin, you can see the cranial floor, the greater wing, and the cribriform plate just below the level of the Christogalli and the superior orbital margin. The Petrus ridges always appear in the lower third of the orbit for the Caldwell projection. Now, this is not a Caldwell projection. This is a straight PA projection. And the difference is the Christogalli has dropped down about 1/4 of an inch, right? And the Petrus ridges have risen up about 1/4 to 1/2 inch. The Petrus ridges now, the Petrus pyramids now are said to fill the orbits, or almost fill the orbits here, okay? So we can see the maxillary sinuses, and we can see the ethmoid, and now we can see the lower, the middle nasal concha, so more complete view of the ethmoid bone in the straight PA skull, okay? You can see the vertex, you can see the frontal bone in the straight PA. It says dorsum celli there. That's really tricky to see. It's kind of superimposed with the Christogalli. There's a better view of the dorsum celli on the Townes projection. Okay, frontal sinus is foreshortened a little bit on this projection. It's elongated a little bit on the Caldwell projection, so we get a better view of the frontal sinus on the Caldwell. The straight PA shows the frontal bone, the superior portion of the frontal bone, just a little bit better than the Caldwell projection does. Okay. So Caldwell projection is often looking at the frontal bone, looking at superior orbital margins. PA projection is more looking at the frontal bone and its junction to the parietal bone and the more superior portion of the frontal bone, because we've actually increased the superimposition of structures in and around the orbits for this projection. So the whole point of the 15-degree down angle is the structures around the orbits spread out a little bit, and the Petrus pyramids descend a little bit on the Caldwell projection, so you can see more of the orbits on a Caldwell than you can on a straight PA. All right, so APPA axial projection, you can do, when you're in a trauma, you can substitute a reverse Caldwell if you have to, okay? Now, it's going to, when you substitute an AP for a PA, the PA is the standard projection. When you substitute an AP for PA, you're magnifying the orbits and the borders of the orbits. You're also magnifying the frontal bone and the coronal suture. It's just farther away from the image receptor. But sometimes you're in trauma setting, so you can't exactly do a true Caldwell or a true PA. You've got to substitute a reverse Caldwell, okay? In the reverse Caldwell, angle 15 degrees cephalad rather than 15 degrees caudad. In both of those, the AP and the AP axial projection, direct the central ray to the nasion. Have the orbital meatal line be vertical if you can, okay? If you can't manipulate the patient's head because you suspect a C-spine fracture, angle the tube such that the central ray is running parallel to the orbital meatal line. And I'll show you that when we do the live demonstration about how I've got a patient with I can't tip their head up and down because we suspect a spinal cord injury. So I'm just going to use a tube angle to get a true PA or a true AP that runs along the orbital meatal line. All right, now this is the Townes projection, so I didn't show you. I hope that I've got it on an upcoming radiograph, upcoming slide. It looks like we advanced to the image critique, and I'm talking about the image critique before I show you the actual projection. So I'll have to fix that on next year's lecture and get that. Hopefully I have it coming up. But for Townes, I want you to remember downtowns. For the Townes projection, it's a 30-degree caudal angle. This is an AP projection, and it is directed to a point 2.5 inches superior to the glabella, which is usually where the natural hairline is. Now, some of your patients will have male pattern baldness, so their hairline will vary. LeBron James. Excuse me. Had something in my throat there. Anyway, yeah, 2.5 inches superior to the glabella, 30-degree caudal angle. Now that's when the infraorbital meatal line, no, the orbital meatal line is running horizontal or perpendicular to the image receptor. Now, what can you see on this? Well, we can see the dorsum sella superimposed over the foramen magnum. Now, remember the dorsum sella is like the backrest to the Turkish saddle, the sella turcica. So that's what we're going to be able to see. The foramen magnum, of course, is the orbital. It's on the occipital bone. On the base of the skull, it's the exit of the spinal cord from the brain. So the medulla oblongata is passing through the foramen magnum. Posterior clinoid process, remember those are just the upper corners to the chair back, right? And then the petrous ridges appear to be pointing, sloping downhill, roughly for mesocephalic head, roughly 20 degrees downhill, pointing at the foramen magnum. And then, of course, if you have a different shaped head, that's going to be either a steeper, I would say it's going to be steeper for the dolichocephalic. You're going to see it's going to be more like 35 degrees downhill in toward the center. And then for the bradycephalic, it's going to be flatter. It's going to be more of like a 15 to 10 degree angle. But anyway, the petrous ridge is going to be, they should appear symmetric. We've got a little obliquity in this radiograph. Notice how the foramen magnum is closer to the right side of the image than it is the left side of the image. And it looks like the petrous ridge on the patient's left is larger than the petrous ridge on the patient's right. Well, that's because the patient's obliqued slightly. Now, where are the orbits? They're actually below. All the facial bone structures are below the petrous ridges. So what is this trying to show off? It's trying to evaluate the occipital bone and the parietal bones because that's what's actually closest to the image receptor. So we've completely, with that 30-degree down angle, we've completely removed the facial bone structures from the skull. We can't see the facial bone structures. They're running off the bottom of the radiograph. And the petrous rear pyramids have been shifted out of the way of most of the occipital bone and the parietal bones. Now you see the bright spot in the middle? That's where the occipital bone gets really thick. That is the superimposition of the external occipital protuberance, which is called the inion, and the internal occipital protuberance. So the occipital bone gets a thick bulge in the squamous both on the external surface and the internal surface, roughly in about the same area. So it corresponds to increased attenuation in the middle of what would otherwise be uniform attenuation. So the squamous portion of the occipital bone always has a bright spot in it, and that's always the internal and external occipital protuberances superimposing with each other. And it should be right in the middle of your radiograph if you do the Townes projection correctly with the correct centering. Now, just above that bright spot, you should, sometimes it shows up, sometimes it doesn't. The lambdoidal suture should appear on this radiograph. See where it says parietal bone? You can almost see the lambdoidal suture just below that. And then also the sagittal suture should appear at the very top border of the skull between the left and right parietal bones. Okay, all of that happening above this bright spot here in the middle of the radiograph, which indicates the internal and external occipital protuberance. All right, so this, yes, good, I have it. So the orbital meatal line, so you're going to have to tuck the patient's chin, the orbital meatal line perpendicular to your image receptor, and then direct your central ray at a 30-degree down angle, 2.5 inches superior to the glabella. And what you should find, see how the black line kind of wraps around the patient's head? It should pass over the top of the ear attachment and exit the base of the skull. Okay? So think about the sella turcica, which is just superior to the EAM. Sella turcica should be on the line of the central ray, and the foramen magnum should be or just below the line of the central ray, but the line that passes through where you think the foramen magnum is and where you think the sella turcica is should be running parallel to your central ray. So if you were to imagine where the patient's spinal cord was, right behind the ear, at the level of the base of the skull, and then draw a dotted line to where you think the sella turcica is, and you should notice that that line is parallel to your central ray. Okay, now what if your patient can't tuck their chin that much so that the orbital meatal line is running parallel to the image receptor? Well, there's an alternate version that you can do. The alternate version is a 37-degree caudal angle with the infraorbital meatal line perpendicular to the image receptor. So some of your geriatric patients might find that that position is more comfortable and that they don't have to tuck their chin as much, and then you just increase your tube angle to compensate. Remember when we were learning the topographic lines that there was a 7-degree difference between the OML and the IOML, and so that explains the 7-degree difference in the tube angle between the two projections. All right, so how do we evaluate our Townes projection? This would have been helpful if it had followed the radiographic example, but we don't want rotation. Now, we should see that the lateral edge of the skull, there's a distance or a thickness, space between the lateral border of the skull and the lateral margin of the foramen magnum. In other words, the foramen magnum should be centered to the skull. If the foramen magnum deviates and is closer to one side of the skull than the other, well, the foramen magnum is definitely on the mid-sagittal plane. So that would indicate obliquity, or the patient's head is rotated one side or the other. Okay. Also, the petrous ridges should be symmetric. Okay. Now, the dorsum sella and the posterior glenoid processes should be superimposed over the foramen magnum. If they're not, then either your tube angle is wrong or your patient's head is not tipped properly front to back. Okay, so that's a problem of tube angle or part position tipped front to back. Penetration of the occipital bone without excessive density at the parietal bones. That's the tricky part, is because the parietal bones are not as thick as the occipital bone is. All right, so I do have, now this is the Haas projection. This is not the Townes projection, slightly different. And again, I've got them in reverse order. So let me talk to you about the Haas. The Haas is sometimes, it looks like a Townes, doesn't it? It's sometimes called the reverse Townes. It's not exactly the same though. Instead of a 25-degree angle, we're going to use a 25-degree or a 30-degree angle like we did for the Townes. We only use a 25-degree angle for the Haas. The Haas method features anatomically, as far as what's displayed on the image receptor, everything that the Towne projection displayed, but also we now get the sphenoid sinuses in between the Peters pyramids, and you can see that indicated. It's immediately inferior to the dorsum celli. Okay, so we still have a foramen magnum, we still have the dorsum celli. Now the dorsum celli is partially superimposed by the sphenoid sinus. The posterior clinoid processes are still showing up fairly well. Peters ridges, we actually did a better job with obliquity on this radiograph than we did the other radiograph. Peters ridges are symmetric about the foramen magnum. They still slope downhill toward the center. And again, the angle is going to be similar. Now it's about 20 to 25 degrees downhill. Because we have less tube angle, they're going to appear a little bit flatter. So more like 20 to 15 degrees downhill for mesocephalic, and then of course plus or minus 5 to 7 degrees for the other two skull types. Okay. Again, we can see the occipital bone. It looks like the lucency, that is the increased attenuation for the occipital protuberances, is still there, but not as clear as what we had in the Townes projection. And we can still see the parietal bones too at the very top of the radiograph. Orbits, facial bones, the mandible, all that's been collimated off and has been thrown to the side by the angles. So let's see how we shoot this thing. All right, there you go. Haas projection. This is, of course, the prone version. You can do it standing up. Orbital meatal line perpendicular to your image receptor or your table surface. And then your central ray is directed to a 25-degree cephalad angle this time that passes through the EAMs on each side. You see how that works? So it's not exactly the same center either. Okay. So again, 25-degree cephalad angle toward the head. The OML, the orbital meatal line, that's the white line connecting the EAM to the outer canthus of the eye. That's going to be perpendicular to your image receptor. And then your central ray is going to pass through a plane that intersects both EAMs. Okay? So what can you see? You're going to see the dorsum celli and posterior clinoid process over the foramen magnum, just like you did in Townes. But now you're going to see the sphenoid sinus immediately inferior to the dorsum celli. Okay? You're going to see symmetric Peters pyramids. You're going to see a symmetric foramen magnum. If either of those are not true, then you have obliquity. If you don't see the dorsum celli and the posterior clinoid process inside the foramen magnum, or you don't see the sphenoid sinus superimposed with the inferior portion of the dorsum celli, then you have tipped the patient's head incorrectly or your tube angle is incorrect. And you should see the entire border of the cranium in both of these projections. All right, I've done it again. So here is your image critique for your SMB. Now this was done with a phantom. There is a neck attached, but good luck getting your patient to be as flexible as this phantom is. So the SMV is a submento vertex projection. Well, what's the rule for projections, guys? Go all the way back to chapter 2. Projections describe the path of the central ray through the body part. So we learned the mental point when we learned the Fuchs method. So submento means the central ray enters underneath the mental point. Vertex means the central ray exits the top of the skull. And now you know how to position for a submental vertex projection. You are going to, you remember the Reach toothbrush commercial? It was the cartoon drawing, and the guy had a flip-top head to brush his teeth. That's exactly what you need to pull off a proper position of the submento vertex projection. You need a patient with a flip-top head so they can get their head all the way back so that the infraorbital meatal line is vertical on a standing radiograph of the SMV, parallel with the image receptor on a supine radiograph. I've never seen this done supine. It's either done standing or sitting. It is really difficult to, you're going to have to build the patient up on like a sheet of foam and then have their head hang off the edge of the table or something. That would be the only way to do it supine. And then support the image receptor with a chair and a foam block or something like that. That's the only way to do it with the patient laying down. Standing up, you need a flip-top head. Now, where do you center? You can kind of figure it out. Just look at the center of this radiograph. You see the mandible. You can see the mandible, can't you? Yeah, there's the mandible. It's indicated for you. You can definitely see the teeth of the patient coming off of the mandible. Well, that indicator on the right-hand side, that's actually the, excuse me, that's the coronoid process of the mandible. And if you follow that backward through the line that says sphenoid sinus, that's actually the TMJ joint. And then halfway between those two, that's the angle of the mandible. Okay, so that's the key to this radiograph is the gonions, the angles of the mandible. You want to put your central ray on the intersection of the mid-sagittal plane and the line that passes between the patient's gonions. That is the angle of their jaw. So submento means you tip their head back, you find the angle of their jaw, and you draw a line between that, and that should form a crosshair with the patient's mid-sagittal plane. That's exactly where you want to direct the crosshair. Okay. Now, the infraorbital line has to be, how far do they tip their chin back or tip their head back? Extreme extension is how I would call this. Okay. Your 80-year-old patient is not going to get into the optimum position. Some of your 40-year-old patients won't be able to get into this position. Okay. There's a cheat for it though. So I'm going to teach you the cheat when I show you the radiographic position on the next slide. Okay. But for standard position, the mid-sagittal plane is perpendicular to the image receptor. The infraorbital meatal line, the line between the EAM and the bottom border of the orbit, is vertical or parallel to the image receptor. Direct your central ray to the intersection of the mid-sagittal plane and a line that connects the angle of the jaw on the left side to the angle of the jaw on the right side. If you do it correctly, you should see the ethmoid sinus and the sphenoid sinus from below. The maxillary sinus should be occluded by the patient's molars, and the orbits also occluded by the patient's molars. Okay. You may see the foramen magnum. You may see the dens and the anterior arch of C1 immediately posterior to the oral pharynx. So it goes ethmoid sinus, sphenoid sinus, oral pharynx, anterior arch of C1, odontoid, foramen magnum. Okay, and then occipital bone superimposed by the patient's cervical spine. And mastoid processes and petrous pyramids just posterior to the jaw. Bilateral EAMs just anterior to the petrous pyramids. Nasal septum. Now, if the patient is rotated, if their head is rotated, well, then the jaw should appear asymmetric, and you may see one of the two TMJ joints. I paused just then. Mr. Shepard had a audio call that he was walking through. So because when we get to the TMJ joints, or not the TMJ joints, the zygomatic arches are oblique variants of the SMV projection. So if you see one of the zygomatic arches flaring out, but the other one is kind of tucked behind the mandible, and the mandible is asymmetric to the mid-sagittal plane, well, then you've obliqued the patient. Congratulations, you've done a zygomatic arch projection. Unfortunately, you're trying to do a perfectly symmetric SMV projection. Okay. The petrous pyramid should appear symmetric. The odontoid, if you can see it, the sphenoid sinus, and the nasal septum, provided it hasn't been fractured previously, should all be on the mid-sagittal plane and should all be at the midline of the radiograph. This is how it looks. Yeah, no problem. Get your sweet little old lady that has got some, it's got a fused cervical spine to do this. No problem. All right, so what's the cheat in trauma? Remember the third rule of trauma? When you can't get proper alignment between the body part and the image receptor, maintain the proper relationship between the central ray and the anatomy. Sacrifice the relationship of the anatomy to the image receptor. In other words, if your patient can't tip their head back this far, get what you can, tell them to hold, and then apply a cephalid angle until the central ray is perpendicular to the IOML. And then just move the image receptor to catch the axial SMV. It will be elongated, but it'll be good enough. Okay? So I'll say that, I'll walk through that again. If your patient can't tip their head back this far, then the IOML is not going to be vertical. It's going to be leaning out toward the X-ray tube. Okay? Well, if you look at the central ray indicator to the IOML on this image, it's a perpendicular relationship. Okay? So if the patient is leaning their head slightly forward from this, then you're going to need to angle upwards, that is angle superior or toward the patient's head, cephalidly, to maintain a 90-degree relationship between the patient's IOML and the central ray. Now what's going to happen is you're going to put about 10 degrees of angle on it, and then you're no longer going to be in detent, so raise your image receptor up so that you appropriately catch the newly modified axial SMV projection that you just made up on the spot, because your patient couldn't flip their head back far enough. It's very hard. When I first started teaching, I was able to do this. Last year and the year before, I wasn't. So that's the effect of aging. I'm losing my flexibility in my neck. So I don't attempt this one anymore. It was difficult the first year and damn near impossible last year. So it's just people get older. All right, so I do apologize for the background noise. Mr. Shepard's having an audio call, so you might hear some like Charlie Brown's teacher sounds. I apologize. So what do we want to see? We want to see proper collimation. You really, it's pretty clear where the end of the skull is. The soft tissue is pretty clear. If the skull's inside, and if the skull's is very much like the femur. If the bones aren't inside, you're going to know even before you shoot the radiograph. So keep your collimation to the soft tissue border. The skull is going to be inside the soft tissue border. No rotation or tilt. Equal distance from lateral border of the skull to the mandibular condyles. In other words, the mandible symmetric to the skull, and then the petrous pyramid symmetric as well. Sufficient penetration to demonstrate structures of the cranial base. So you should see the features of the occipital bone and the mastoid air cells within the petrous pyramids and the mastoid processes.